So, thank you again. I am probably the only speaker today who is not an expert on EMEA CFS, but I am an expert on clinical practice guidelines. And we published a guideline which was, let's say, evidence-informed consensus guidelines on chronic fatigue syndrome, or EMEA CFS, just 1 year ago. And that's why I think I'm speaking here now. I have no other conflicts of interest regarding this topic. So why were consensus guidelines needed in Finland? Previously, there were no national guidelines regarding the disease. And according to patients, but also clinicians' experiences, the care of EMEA CFS is often suboptimal and also unequal. So in some parts of the country, you can get better treatment than in some other parts. It was actually the Finnish Parliament who decided to sponsor the production of national guidelines. And I happen to know that active patient organizations were pushing for that. We in Duodecim, so Medical Society, noticed that the number of high-quality clinical studies on EMEA CFS was very limited, and thus recommendations, if we were using strict evidence-based medicine methodology, would have been very difficult to formulate, and thus we offered the Parliament the possibility to produce consensus-based guidelines, and that was accepted. We have. So I already told you that we published our guidelines 1 year ago. There are 10 domains, and these domains are described and decided by the guideline panel. Guideline panel consisted of 19 members. Part of them were doctors, but there were other professionals and also patients participating in the panel. Each domain, or almost each domain, have statements or recommendations, and those recommendations needed to be accepted by the panel with 75% or more consensus. Then each statement has justifications published as some short summaries, and they were accepted by the writing group but discussed in the panel meetings. And then there is a large volume of additional comprehensive justifications as background data, and they also were accepted by the writing group but discussed in the panel meetings. So here are the domains. The first domain was how do we name the disease, and this was actually the only domain where no consensus was reached. And thus, in our guidelines, we call the disease with the term chronic fatigue syndrome, EMEA CFS. The other domains were clinical characteristics and diagnosis, treatment and rehabilitation, organization of care and rehabilitation, assessment of ability to work and function, rehabilitation other than medical, guidance of social services for healthcare, special needs of children and adolescents, legislation, and then research needs. There were altogether 61 statements, and I will now show you about 15 of them. I only go through the statements. I am not going to give you any background data about the statements. So we start with clinical characteristics and diagnosis. We recommend to use of those diagnostic criteria that include post-exertional malaise. So we feel that it's a patient needs to have PEM before diagnosed with EMEA CFS. Then we recommend that examination of and necessary symptomatic treatment for fatigue that markedly decrease patient's ability to function is initiated without delay. So you initiate the support and treatment before you can get the diagnosis of EMEA CFS. And we recommend that the diagnosis of EMEA CFS is not set until the significant symptoms have persisted at least for 6 months. Then about treatment and rehabilitation. We recommend that symptomatic treatments are individually tailored and medically justifiable. With medically justifiable, we mean that they must be evidence-based symptomatic treatments, and most often they are expressed in other guidelines than this EMEA CFS guidelines. And also we recommend that especially for patients with EMEA CFS, possible benefits and harms should be closely monitored. Then we recommend that an individually prepared plan of physical activity addressed as part of other treatments and rehabilitation is done. And this plan should be decided multi-professionally and in cooperation with the patient. And thirdly, we recommend that activity pacing should be considered as part of the treatment. Then about psychological interventions, we recommend that psychoeducation, which means informing about the disease, giving information about the disease and prognosis, can be applied as part of multiform treatment and rehabilitation of EMEA CFS. Talking about the cognitive behavioral therapy, our recommendation is that psychological interventions can be discussed and information about them given to those patients who have simultaneous concurrent psychological distress. But psychotherapeutic or psychosocial interventions are provided only to those patients who choose to try them. Then I continue about the off-label treatments. We do recommend that if off-label drug treatments, and as you have heard, there is a long list of these off-label drug treatments, are considered to be essential, but there is no sufficient data regarding their efficacy and safety, and they are not included in the commonly accepted treatment choices. The expected benefits and possible harms are very closely discussed with the patients so that she or he, the patient, understands and is in reality capable to make a conscious choice of the treatment. And we also recommend that this kind of label drug treatments of the disease are offered only in such healthcare units that are capable to support adequate know-how and experience of the treatment of the disease, and the centers also must be able to arrange adequate follow-up. About organization of the care, we recommend that regional seamless care pathways for patients with EMEA CFS are described in cooperation with primary care and special health care providers, and also that necessary training to put those in practice is provided. Then we recommend that the care of patients with severe or complicated disease is organized in such healthcare units that have adequate know-how and experience in treatment of these patients. And we also recommend to establish a national, so Finnish national network of centers with special knowledge on the disease. Just a few words about children and adolescents. When diagnosing EMEA CFS in children or adolescents, we recommend the use of international pediatric diagnostic criteria published on 2017. These criteria include PEM. Then we recommend that for children and adolescents, a physician well familiar with chronic fatigue, with EMEA CFS, as well as a specialist in childhood or adolescent medicine are included in diagnosis, as well as planning the care. Of course, it would be a best thing if the same pediatrician could be familiar or specialist also in EMEA CFS, but this most often does not happen to be the case. School has discussed earlier We recommend that to enable school attendance, so compulsory education and studying, an individual plan should be made for each child or young person with with ME/CFS, and this plan should be done in cooperation with the child, family, school community, and school or student healthcare. And finally, we recommend that the continuity of care of an adolescent with ME/CFS is taken care when she or he is transferred from children and adolescent services to adult services. And just I will finish with a slide about my experiences when producing these guidelines and some discussion about. So our experiences show that national consensus guidelines on the disease, on ME/CFS, even when it is a very complicated situation, can be produced by medical societies, but in cooperation with other stakeholders. Then even when there is only limited scientific evidence of various interventions, national guidelines can have a role in guiding the care and in sharing information among professionals and patients. And these also, of course, have been shown by NICE in England also. I feel that it is of utmost importance to include various professional groups, different opinions and opinion leaders, as well as patient organizations in guideline work when you are producing a guideline on ME/CFS. So with this, I mean that somebody was talking about believers earlier today. In this kind of consensus group, there must be believers, but there must also be non-believers, because if all are believers, then no consensus. The consensus doesn't really mean anything. However, it remains to be seen what kind of influence do our guidelines have on the treatment of patients. We already know that active implementation is definitely needed. And I want to finish on saying that I'm most grateful to the Finnish guideline panel, and especially to its patient representatives, Nadia Kiiskinen and Samuli Tani. I say this because discussions with Nadia and Samuli, as well as the discussions with other patients before we started the guideline and while preparing the work, have taught me a lot about what it means to live with ME/CFS, although I, in my clinic career, have not been taking care of these patients. So I will finish here, and thank you for your attention. Thanks.
Thank you so much, Dr. Jorma.